So thanks everyone on the panel. And I'm going to start perhaps with the first question, a couple of questions actually that came from I think Dr. Sheikh, who's a neurologist, and I was really happy to see these questions because certainly this is something that I don't have a great amount of knowledge on. The over-the-counter supplements that are used to help somebody fall asleep, and I suspect that that many of my patients before coming to me have gone to through various medications that they've tried, either whether they're over-the-counter sort of Benadryl or other supplements. And I'll direct the question to Dr. Kozlowski first, which is, which over-the-counter supplement, would be best for somebody, or do they work? And what your perspective on that might be. So, Dr. Kozlowski.
Thank you so much. And thank you so much to the Whole You team for having me this morning. So just to ground the audience, so I work in a non-traditional pharmacy setting. I work for Amgen, which is a biotech company. So I'm not working directly with patients. I'm more on the regulatory side. I interface with different health authorities, such as the FDA. And as many of you are probably aware, the FDA are the gatekeepers for ensuring that products, including medications, are safe and effective. But one thing to be aware of is that they do not regulate vitamins and supplements the way that they regulate pharmaceuticals. So there's a big misconception among the patient population that just because they see something as natural, it's automatically safe, which is not true. There's a whole plethora of different supplements out there, anywhere from melatonin to valerian, which could be very helpful. And I'll definitely rely on my peers here today who do interface with patients to, go into a deeper dive into what they specifically have seen anecdotally with their patients. But I think just coming from the regulatory perspective, it's really important to be aware that these supplements are not regulated and are not examined under the same level of scrutiny as prescription medications. There are also a lot of over-the-counter medications, which can be really beneficial because, as you're aware, they're very affordable and easy to access, but again, those are regulated, but again, not to the same level of scrutiny. And what I would advise are for patients to ensure that they are still consulting with their healthcare providers to ensure that there aren't any interactions with other medications, also taking into consideration any comorbidities that they have or medical history as well.
Yeah, Dr. Sheikh, since you asked this question, I'm curious. Do you see patients come in with any particular over-the-counter supplement that you've seen more than others or have worked better than others?
Yeah, so I mean, I asked this question because most of what I see and most of what I see in the office is migraine. That's 90 to 95% of my practice. And for me, I tell all my patients that sleep is such an important part of helping to decrease migraine frequency and severity, in addition to things like stress. And a lot of my patients, they're young women, so they want to do things that are much more natural. So for things like stress, I encourage things like mindfulness, yoga. But for the sleep aspect, a lot of these young women are working, they're young mothers. So it's very hard for them to stick to a sleep hygiene, which really means, trying to go to bed at the same time, skipping caffeine, skipping alcohol. So a lot of these patients want something that they can take when they're about to go to bed and try to get a really great night's sleep. So I do hear of a lot of patients who try melatonin, that is over the counter. They can get it at their pharmacy. It's hard because I've heard a lot of different things about which doses are the best. And then CBD is another big thing that people are starting to try, and they notice that some notice it is helpful, others aren't really sure. And some things help you fall asleep, but then patients will notice that they're waking up 3-4 hours later. So another big thing about sleep is that they want to be able to fall asleep fast, but then actually stay asleep for 7-8 hours without interruption. So we have some migraine preventives that also help with sleep. things like amitriptyline. So we tell patients to take it, not in the morning, but before, a couple of hours before bed. So we have some strategies that we use, but to be quite honest, even though we stress sleep so much in migraine and in stroke, it's, sleep is another risk factor. In migraine particularly, it's a huge trigger for a lot of patients. If they don't get a good night's sleep, they know the next day they're more likely to get a migraine attack. So I asked the question because honestly, I don't have a great answer to it myself for my patients.
Absolutely. And maybe I'll ask Chris Lotito or to chime in about melatonin, because I agree that's something that I see a lot of. Are there any particular melatonin supplements that we should be directing patients to, or brands, or dosing, any sort of insights on melatonin?
With melatonin, most of it, you produce it naturally. So as you get older, you're going to need higher doses of it to start with. But generally, we start with like a 3 milligram dose, and then increase as you assess the patient's response, and then see. Once you get into the 10 milligram range, then you're talking about extended release products, which may actually help the patient stay asleep longer, which I know is a concern. So that is another possibility. But then you adjust the dose based on the patient's response.
Yeah.
I have a question about the melatonin. One is my understanding is that it needs to be taken at least 2 to 3 hours before bedtime. A lot of patients are taking it like, a supplement where they're taking it 20 minutes before bed. And regardless of the dose, they say, oh, it doesn't work for me. My second question is something that Chris said is, if your body's producing enough melatonin anyway, as a young person, taking more melatonin, is that going to help, or is it actually going to suppress the body's natural production of melatonin, which may be harmful in the later years if you stop the supplements? Now you're melatonin deficient.
Right, that would be correct. So yeah, sometimes you don't want to go right to melatonin because, like you said, you're already producing it naturally, and the addition of it is not really going to be much more helpful.
Yeah. Can everybody hear me?
Yes, we can, Jonathan.
So first off, melatonin isn't necessary for sleep. It's really necessary to train your clock, right? So you can remove your pineal gland. It's not like people wouldn't sleep. So it's really the dim light melatonin onset that's the inducer, or the signal that tells the brain it's nighttime. And that usually happens around 9 o'clock. And that's way below the doses we're taking, like 3 or 10 milligrams. It's really like 0.5. So if you wanted to try to phase shift, you can use melatonin judiciously at small doses, 0.5, even 0.3. And it has to be taken about 4 hours before your habitual sleep time, your required sleep time. So that's a little complicated, and you can definitely phase advance. You really can't delay patients. So patients that have a tendency to fall asleep earlier because they're older, you really aren't going to move them with melatonin. But the younger patients that are delayed definitely can be moved with melatonin. But so then there's the super physiologic, like we're talking about. And the study's even up to 20 milligrams of that. The problem with melatonin, and that's why Ramelteon, which is synthetic melatonin, isn't a popular drug. The problem is it's so short acting. Like I'm sorry, I missed your name there. Christopher was saying. So that's why the extended release products may be more helpful. But in general, it's not the most powerful agent. Some patients obviously respond very well, but usually we're left with patients having, like I think Dr. Sheik mentioned, but the problem is really, and that's the more common phenotype with insomnia, is that patients don't actually maintain sleep. It's not really sleep initiation that's the biggest problem, it's maintenance of sleep. That's why melatonin often falls short, because it doesn't last long enough.
My own experience with melatonin, completely unscientific, is that there are some people who love melatonin and they fall asleep and they swear by it, and other people, they use it and just don't have any effect at all. And I suspect that there's obviously insomnia, there's a lot of power of suggestion and placebo effect and things like that. So I sometimes wonder about, does the placebo effect play a significant role in any of these supplements? Just as an observation on my end.
If I may, in my setting at the retail level, many of my patients do take a sustained release product, which they feel works better, but it's also a dissolving product that dissolves in their mouth and is absorbed through their bulk, through the mouth. And when it does, people that take the one that they actually swallow, it goes through that first pass metabolism, and it does not work that well. Most of it does get destroyed when you swallow it. But by taking the oral disintegrating tablet, it does work much better. And I do get patients that tell me that they do get sleep results from that.
Interesting.
Well, that's very helpful. Thank you. So is there an answer to this question, best OTC supplement, which is best? Is there anybody have any input on that, a best one?
So most of the OTC we're talking about are going to be either they're going to have some antihistaminergic or sometimes anticholinergic effects. So that's the most common ones. And there's nothing wrong with that. The problem, obviously, the difficulty in any sleep tonic is not only in initiating sleep, but also, like we said, Dr. Sheikh mentioned, is maintenance of sleep. So the problem is you don't want the drug to be present when you wake up the next day. And that's really the trick of trying to find a good sleep product that works. And there's definitely strong evidence for hypervigilance in the chronic insomnia patients. That's why also, like I was saying, really, you don't get a tremendous response in the majority of people from melatonin alone, because it's not really, the strongest inducer of sleep is actually adenosine, which we don't really have a drug to mimic that. Sort of the anti-caffeine drug would be an interesting medicine. But Barry, there's the majority of those products are over the counter, like I said, are going to have antihistaminergic effects.
Yeah, like the Benadryls or
yeah, or the dicyclamines or the what's it called, Zequels.
If I may, in my setting, we sell the CBD oils and capsules, and we do have patients that come back frequently for these products, and they take it for many different reasons. And they do tell me, the feedback that I get is that they do have a more restful sleep, and during the day they are much more focused by taking these CBD oils. And they're very easy to adjust the dosing, because we sell the oils and you could adjust by just the amount of drops that you ingest. Right. So that's one product that seems to be taking on very quickly.
Interesting. All right. Thanks for that. I think, it is one of the sort of issues that we struggle with a lot. Just, when patients come in and ask for, hey, can I have something non-addictive? Which sort of, before we go to the next question, a quick comment maybe about long-term effects of melatonin. Should we be concerned at all about somebody who uses, 10 milligrams of melatonin for, 3 or 5 years? Is there any data to show its safety profile? Anyone? Dr. Yeah, I think for me, I have not been concerned about the long-term effects of melatonin, but I don't know whether that's valid. The next question really is sort of going to be more focused on and again, from Dr. Sheikh, I believe this question was, which is about which medications outside of over-the-counter work best for insomnia. And here, I certainly think that there's going to be discussion about side effects. But again, let's start with Dr. Kozlowski. We'll go round robin with the room. What is the most common sort of or actually prescription insomnia medication that you see, and is there any concern about those?
Thank you for this question. Again, unfortunately, this is slightly out of scope for my day-to-day practice, just because, like I mentioned earlier, unfortunately, I'm not patient-facing in my role. However, just from what I've pulled up from this Harvard Medical School sleep report, it has a list of the top prescription medications for insomnia. So I'll just provide that for the sake of this discussion. Benzodiazepines, non-benzodiazepines. The benzos are usually for short-term treatment of insomnia. The non-benzos for insomnia, antidepressants, including SSRIs and SNRIs, melatonin receptor agonists for insomnia and circadian rhythm disorders, and then finally, orexin receptor antagonists for insomnia. So I thought I would just include that, but as I mentioned, unfortunately, I don't have any anecdotal evidence to support my interactions with patients regarding this. But as I did mention earlier, I think from the regulatory perspective, which is where my experience lies, I would say that it's certainly important to consider all this, as you mentioned earlier, the side effect profile, the patient profile, including any predispositions or comorbidities, as well as their complete list of any other medications they're taking, including supplements, which could potentially interact with those medications.
Right. Thanks. I think those comments are really important. And I think all of us who practice in our in clinically, important to sort of remind the listeners that obviously medication is usually not the first option, right? For insomnia, we usually try sleep hygiene and cognitive behavioral therapy. Unfortunately, those resources are somewhat limited. And we end up using these medications. I think one concern area for hypnotics in general and sedatives is as we age, there seems to be some significant issues, both with sleep fragmentation, where people are not sleeping well, but also the side effect profiles sort of increase. And in my own practice, one of the most difficult areas is when you have somebody with maybe mild dementia whose sleep sort of patterns are falling apart. And how do you treat them appropriately with medications, or should you be avoiding medications altogether? Interested in perspectives on that, if anybody has any. Jonathan, you probably have similar patients as I do.
Yeah, the only medicine that really got any kind of approval for insomnia and dementia is actually suvorexant. Unfortunately, it hasn't really been studied, or it has been studied, but it hasn't really gone through approval. I mean, there's definitely data in melatonin, in doses as high as over 9 milligrams in demented patients in terms of improving sleep, but it is a huge problem. But it's interesting that suvorexant actually worked. It really had a pretty low dose, 5 to 10 milligrams, but it is a pretty safe agent overall. But the problem, what you mentioned about CBTI is, interestingly, you never actually improve total sleep time. So CBTI never recapitulates a normal total sleep time. You definitely have improvement in WASO, in arousals, but believe it or not, that's why often you kind of need more. I know a lot of people kind of poo-poo sleep tonics, but I use them a lot because unfortunately it's very hard to shut down that hypervigilant state in patients.
Right.
Obviously, CBTI is definitely something we should all utilize, and there's actually some decent online services now that we utilize because we don't have a CBTI therapist in my office, but
yeah.
And then
Sorry, you said, I missed what you said that we should utilize. You said CBTI, like.
So cognitive behavioral therapy for insomnia has,
Right.
pretty good literature on it.
Right.
Interestingly, all the different forms of CBTI never actually recapitulate a normal total.
Right. Right.
Interesting. Which means that you're only the big thrust with CBTI is really the cognitive component, not the behavioral. Behavioral components are kind of easier. It's the cognitive, trying to, have somebody not ruminate about their inability to fall asleep.
Right.
And so that's the biggest obstacle. But what I was saying is that invariably, if you really want to normalize patients, you often need more than just CBTI. And that's where obviously medications come in. But the last interesting thing I just wanted to say, which was actually a study on suvorexant, not that I'm focusing on a suvorexant, was one of the reasons why the sleep tonics work, which is a bizarre one. This is very bizarre. is that what they do is they actually don't decrease arousals, they decrease the arousal time. And that was pretty clearly shown. That was actually about 2-3 years ago. That was clearly shown with suvorexant. So what that means is patients still wake up, but the amount of time they spend awake shortens dramatically. And then the perception of sleep actually improves, which is a weird mystery. That means that if the patient perceives they're sleeping better, it actually translates into them feeling better. You know, you could use the two ends of the spectrum. You could say, I have a sleep apnea patient who has a lot of fragmentation in sleep, and the fragmentation is relatively short. You stop breathing, they may wake up for as minimal, by definition, it has to be at least a 3-second arousal for it to be called an arousal. So they're waking up for 3 seconds, it could be 10 seconds, obviously it could be longer, but the majority of bad OSA patients don't stay awake for that long, but they have a lot of interruptions. When you ask them how they slept the next day, they'll tell you that they slept fine. Most of my sleep apnea patients are confused. How could they have sleep apnea? Because they think they sleep fine. Whereas the other end of the spectrum, the classic phenotype of insomnia, they'll tell you that they didn't sleep well at all. They're convinced that they didn't sleep at all because every hour they're up for 5, 10, 15, 20 minutes, and they record that. And so in the morning, they think they have horrible sleep. And what I was saying is that the sleep medicines seem to actually not decrease arousal so much as decrease the arousal time. And that translates for unclear reasons into them feeling better. Because if you actually look at the shortened, how much time you're actually improving in total, in terms of total sleep, it's actually not that much. It's 30 to 60 minutes of improvement in total sleep time. And if you think about the average person's perceiving, oh, I'm only sleeping 5 hours, that's only 6 hours of sleep. But yet it often will translate into them feeling better.
Do you recommend, I'm sorry to interrupt, but do you recommend routinely doing sleep studies, or is there something specific in their history or what they're describing that will push you towards that? Or is that something you would like to do in a lot of patients just to get a baseline?
I'm sorry, were you saying this to me or just to the?
Just in general. I mean, I think because I will only really consider sleep studies if patients are describing symptoms of sleep apnea, but I don't routinely do it for insomnia or, other sleep issues.
Yeah, it's a great question. So the problem is about 30 to 50% of OSA patients will present with insomnia type symptoms. So it's kind of hard to discern. Now, granted, some would say, oh, you should have a high clinical suspicion before you're going to do a sleep study. I mean, and this is obviously anecdotal, but the way we do it is we do actually a lot of home sleep testing because I want to make sure you don't have something obvious that I can fix in terms of fragmentation. I mean, I would say the overarching problem is sleep fragmentation in almost all major sleep problems where patients have EPS or don't feel well the next day. It's often sleep fragmentation is the problem. But so OSA is obviously can fragment your sleep.
Right.
That's one of the reasons why I want to at least screen for it, because it's something I could treat. And even UARS can cause a lot of sleep fragmentation. But so to answer your question, my practice is probably different because we have a very low threshold for screening them. And because I realized, listen, there's definitely some classic phenotypes that you're looking for in terms of OSA, obviously obesity and large neck, but about a third of patients aren't obese or overweight. And the problem is after age 60, the association between weight and risk of OSA kind of disappears. So especially in an older population, they could have OSA and don't have classic, features of OSA. And then other things like Mallampati don't really pan out very well. So it's kind of hard to actually screen and be confident that they don't have it and dismiss that. But it sort of depends. Young, healthy females that are premenopausal, I usually defer initial OSA diagnostic treatment or studies because the majority of them don't tend to have bad OSA. They may have UARS that could be a fragmenter. I don't know if I answered your question though, but
no, that's what you did. You did.
I'd like to chime in on this too, because I have a lot of, clinical experience, exactly what Dr. Lown is saying. And I find my answer would be do the sleep study because, we can measure apneic arousals with the loss of oxygen. But as Dr. Lown was saying, I had a patient the other day, spontaneous arousals, off the charts. Rare is respiratory effort related arousals without oxygen desaturations, which are not going to show up as OSA. And then periodic limb movements. There's a lot of reasons why patients have these fragmented sleeps. Dr. Lowndes said the arousals may be short lasting, but you look at their sleep architecture, and they're going to get 60, 70, 80% light sleep, and maybe 1 or 2% through the night is in deep sleep and slow wave delta sleep. So this is valuable information because it gives you, a compass, a direction in which to treat the patient. They may not have OSA, so okay, no CPAP or oral appliance, but especially with upper airway resistance syndrome, as Dr. Lowndes said, these young patients between 20 and 40, maybe they have some snoring issues, which drives them into the practice, and they may have an RDI in the 15 or 20 plus per hour category, and maybe 0 to 2 or 3 apneic events. Their oxygen levels are still in the 90s. Now we have a direction in which to treat them, because insomnia, if you're going to do cognitive behavioral therapy, now we're assigning some kind of cognitive psychological issue to this, usually temporary. But if CBT is not going to work on a patient that has periodic limb or upper airway resistance, and they think they have insomnia or maintenance insomnia, but it's really an arousal issue. So doing that, the answer is doing that sleep study really gives you a barometer, a compass in which way to think about, how we're going to effectively treat this patient. Because, if we're treating for insomnia and they have, these respiratory effort related arousals, now we're a little bit off base. So, do the sleep study, understand the sleep architecture, understand oxygen desaturations, understand what kind of arousals they have, whether they're spontaneous or apneic or upper airway. And then, now we have a better way to treat these patients.
Sure. Thanks, Barry, for that perspective. I think before we go to the next question, I'll ask something that's sort of worrying me, which is that, when you have patients on insomnia medications, what are the chances that they dose escalate or misuse the medications? And, how do you, I know I really rely on the pharmacist to help me sort of manage that and alert us. But Chris or Vito, any thoughts? How do you see patients often that are especially on benzos that are dose escalating and trying to shop around? Is that something commonly seen?
Well, in the retail setting, after so many years of being in this setting, you do see much of that. I think many patients are prone to be dependent on these products, and it's not their fault most of the time. Once they start taking these products, even though it's a low dose, as they continue to take them, they do need more and more of them to feel the effects of them. And unfortunately, they become dependent on them. Yeah. And it's very, very hard. I've seen patients try to get off many of these products, and they have a very, very difficult time in doing so.
Right. Yeah, certainly something that we struggle with in clinical practice as well. Mm-hmm. I'm sure all of us would love to have a medication that works with for sleep apnea. But there have been some interesting data on atomoxetine and oxybutynin. I'm sure it's hasn't been ready for prime time. But as pharmacists, have you seen any patients come in with this sort of combination prescription at all?
I have not. No.
No, I haven't either. In fact, I actually had to look that up to see what how it actually works. It's actually very interesting to see how the combination does affect the patient. And the study that I found was really kind of limited. It was only 20 patients, but it did seem to make an improvement. The question though then becomes, are we treating the symptoms or are we treating the underlying condition? So that just becomes the thought with this combination. So are we really solving the patient's problem, or are we just kind of getting them through the night with this?
Right. And Jonathan, since you asked the question, I'll pose it to you as well. I mean, have you ever prescribed this? Because I have not personally prescribed this combination. I think the studies are super early. The data wasn't that convincing to me, although there were, obviously the statistical improvements in OSA were quite surprising, especially given the mechanisms of action of these medications. But Jonathan, are you using this combination?
No, I mean, I agree with what Christopher was saying there. So it was a small study. It was only 20 patients, but actually the group that published that is actually looking, believe it or not, they're actually starting a small pharmaceutical company to actually get this marketed and obviously approved. And it really was a dramatic reduction in OSA. And then the main reason why was because it really was allowing stimulation or continued stimulation of the genioglossus. They sort of worked it out. This is it's a fascinating topic. That's one of the reasons why I brought it up. Because we know that in a significant percentage of, probably at least a third of patients with OSA, they have a hyporesponsive genioglossus. And the reason why complicated, not to go off on a tangent, the reason why that happens, it's different in non-REM and REM sleep. In non-REM sleep, it's actually loss of adrenergic tone that leads to genioglossus kind of not being responsive. And in REM sleep, it's actually increase in cholinergic tone. So that's why they came up with this regimen. The atomoxetine blocks, atomoxetine is going to increase the noradrenergic tone during non-REM sleep, and oxybutynin will block the cholinergic tone in REM sleep. So that combination made sense, and it definitely worked. Now, the weirdest part about the study is when they did actually as monotherapy. So they had a small group of patients who were just on atomoxetine or oxybutynin alone. It didn't work at all, which made no sense. In other words, they gave atomoxetine only, and that should have at least improved non-REM apnea, and it didn't. And then they gave oxybutynin, it should have improved REM apnea, and it didn't. So that's a weird one. But the reason why I was asking is because I'm not sure how comfortable I feel putting somebody on these meds. I mean, oxybutynin I'm okay with, but atomoxetine at nighttime, as much as it may lower the AHI, I'm not sure what it's doing to sleep. I mean, it's probably going to fragment sleep. Right? It's not like I want to give that medicine in general. I mean, we do a decent amount in kids. I mean, the response in adults for Strattera hasn't been great, so I don't really use it for ADD in adults. But I'm just more concerned about the long-term fragmentation that could occur. That's really why I was posing the question.
The other question about that study was that it looked like it was only done for one night, so yeah, we don't know the long-term effects of it.
Right? Exactly. You don't really know.
Yeah, I think one of the other fascinating areas in regards to the medical treatment of obstructive sleep apnea, I'll say, is there have been studies that show that if you reduce sleep fragmentation, for example, with Lunesta, in those people with a high arousal threshold based obstructive sleep apnea, interestingly, some of the medications like Lunesta can improve OSA symptoms, which I thought was rather interesting as well. And in my experience, you do see patients, especially young patients who have this extremely, I'll say light and fragmented sleep with very mild elevations in their apnea index. They do seem to do quite well, if you address their insomnia and Lunesta or something like that.
Yeah.
Dr. Lau, I have a couple of questions around this. One is, as mostly an oral appliance provider, this would be a great adjunctive therapy along with what I do, not a standalone therapy. If that's what it's, one of the, I know it's early in the game right now, but that was one of my thoughts. My second one would be, like you were saying with the atomoxetine effect on heart rate and blood pressure. I was wondering about that, and yeah, those were basically my two questions around that.
I mean, Barry, that's also one of the reasons why you're asking a great question. It's one of the reasons why I brought it up to the panel is because that's really, if you think about the failure of oral appliance therapy, it's really in the the underactive genioglossus patient.
Mm-hmm.
So you're correct. I mean, that's really where we unfortunately have, these patients have these big drops in oxygenation. They may not be oral appliance therapy. So it's that small segment of the population that has this underactive genioglossus, isn't responding that well to oral appliance therapy. And that's one of the reasons why I brought it up, because it would be an interesting adjunct.
Right.
But like Christopher said, it was only one night and it was a crossover. That's why obviously they are studying this. They're looking to get FDA approval, but that's my big question. What will it do to fragmentation? What will it do to blood pressure?
Right.
You're absolutely right. I don't know.
I wonder if Dr. Van der Veeken has any, since I know he does a lot of work around hypoglossal nerve stimulation, and if
Yes.
Dr. Van der Veeken has any input on this.
Yeah, Dr. Chase and all colleagues, thank you for that question. I believe that this is a very interesting development. And indeed, that might be a similar indication to provide this kind of pharmacological treatment to the same patients that might, at this stage, be the candidates for hypoglossal nerve stimulation implantable therapy. But looking at the results, I agree with two concerns, maybe. A concern is about the side effects in the long run, whereas, for instance, with oral appliance therapy, CPAP, hypoglossal nerve stimulation implantation, we are aware of long-term safety. So that's a difference, I think, with the combination of atomoxetine and oxybutynin. And a second thought that I would have is exactly the same as was mentioned by Dr. Chase before. I think in the long run, a lot of these pharmacological therapies will be indicated as a part of a combination therapy in a well-defined group of our patients, looking at the endotyping and the phenotyping that we probably will have in a standard routine setting in the future, in the near future. So I think it's for a part of the patients, for maybe a niche of the patients, that this will be very interesting in the long run once we know about indication. Thank you.
The next question actually is from you, which I think is a very relevant question. And I think both you and Dr. Pratt probably have legitimate concerns about how the prescription of Zolpidem and some of the other sedatives affect the risk profile. And I'm sure you're thinking it from both a surgical and post-operative perspective. Certainly in bariatric patients, the risk of hypoventilation. And I'll throw this back, again to someone, Kozlowski or maybe Chris. Do you see when you see patients that are scheduled for surgery or something? Are there any special instructions that you give them or warn them about? And then I'll also like to ask Dr. Van der Veeken and Dr. Pratt about their experiences using these hypnotics in the postoperative period, and are they particularly concerned about these?
Mm-hmm.
So I'll say that I usually am fairly concerned immediately post-operatively, and one of my biggest concerns is the effect with anesthetics and whatever other narcotics we may or may not be prescribing in terms of just respiratory depression, really more so than sleep. I think in the postoperative period, sleep's a much different animal just because of the stress response and everything that happens around the time of surgery. But I will say, for most of my patients, I do take them off of all of these medications immediately post-op, and I do take them off of most narcotics. I think the most common things that I get asked about from patients are if they can have things like melatonin.
Mm-hmm.
There's a small percentage of patients that will use things like gabapentin nowadays, which I know we didn't talk about too much. for pain. And what I find with these patients is, and I think other panelists have said this, that when patients believe that it works for them, there's a strong belief there. Whether it's true or it's a placebo effect is hard to tease out. Most of those formulations that they do like using are dissolvables. So they do use those, and I do let them use those. I have no issues with them using any of those medications, but we do try to actually switch them on to medications like that if they feel like they need it, versus something like this.
Right, right. Dr. Van de Weken, any thoughts on your end? Are you concerned about hypnotics post-op or?
Yeah, and I would put a concern even more broad than only like the postoperative period. I think in particular in these patients, but not limited to this patient group, that often it's like people would say, yeah, this is maybe a safer type of medication than some of the other sleep medications. And that then in that context, it's very safe, or you cannot get any problem with that. And that's, I think we should be very cautious with that kind of thoughts, because we do see that indeed they can give a lot of problem, in particular, of course, in patients with severe OSA and or obesity hypoventilation patients. But maybe also in the more mild patients, I would be afraid also in the long run for daily use, for sleeping problems, that they're not that safe, and they might give some problems of addiction in terms of when patient starts to build down the dosage, that they don't succeed building down the dosage, that they get some side effects. And I would love to see or to hear the comments from the experts on what is the true indication of the medication is.
Sure. And I'll just add to that, to your question, which is, and we'll shoot it back to the pharmacist here, is, one of the sort of suggested advantages of, let's say, Ambien or some of the Z drugs compared to, let's say, the benzodiazepines is less respiratory depression, right? And I'm interested to, is that reality? What is the respiratory depression profile of the Z drugs compared to hypnotics, and should we be concerned in that area or not? So
actually, Jagdeep, it actually has been studied. You mentioned it before. There was actually 2 studies with Zapaclone, for example, where they looked at even moderate to severe patients, and there wasn't any worsening of Jenny Glass's activity in that study. And we've also used it in not only to increase arousal threshold, but also in central apnea. Mm-hmm. Central apnea had benefit from using zolpidem. And I mean, the big problem with zolpidem is obviously that it's relatively short acting. That's why obviously this Ambien CR. But in the average patient, it's not an issue in terms of respiratory depression. The question is, when you post-operatively, I don't think it's ever been studied. And if they're on other medications, that might be a different story. So that really, I would be very cautious post-operatively with that. But in terms of the average OSA patient, I use it actually a decent amount. And the other Zapaclone study there was 2 actually. One was improvement in CPAP titration. The other one was just in tolerability of CPAP with the use of Zapaclone. And like I said, it didn't worsen OSA, but in the post-operative patient, who knows? All bets are off. Like I said, I don't think it's been formally studied.
Chris, any thoughts on respiratory depression and the Z drugs or benzodiazepines? Do you get concerned when somebody comes into your pharmacy with these prescriptions?
Well, the concern with the benzos is that you're going to see tolerance to them, and you're going to have increased dosing as you move on with them. So you can increase risk with that. So with the Z drugs and, especially zolpidem, you don't see that as much. You don't see the tolerance buildup that you would see with the benzos. So you see zolpidem used more frequently, but I also see it overprescribed. I mean, patients are using it for long terms, and I think they're just taking it more as a crutch than they are as taking it for actual for actual sleep at that point. So, the concern would be the long-term use of the non-sustained release products.
Well, one of the things I just would make mention, it was actually very interesting, not to go back to suvorexin. You're going to think I'm harping on suvorexin, but it was actually a very interesting EEG power spectral analysis where they compared suvorexin to other sleep tonics, including zolpidem. And I'm not too draconian about it. If I have a zolpidem and they're doing well, I never think twice about it. But what it showed in this study was that you can actually have a real disturbance in sleep architecture with these other drugs, and that's also a consideration. But my rule in general is that patients take it, they sleep well, and most importantly, they're functioning at a high level during the day. They're not forgetting things, they're not out of it, they're not groggy. Then I'm pretty comfortable with it. But it is sort of an interesting question. I mean, I could find the reference to that article. It's a weird one because it shows how crazy the sleep architecture can be with average sleep medicines, including trazodone actually was looked at in that study.
Right. Okay. Wonderful. Thanks for that discussion. I think obviously, insomnia is a huge issue, and we sort of worry about it, in many ways. And I thought, the two new ones that everyone is talking about is solriamfetol and pitolisant. And I think until now, I mean, my practice was, we had modafinil and we had, maybe Ritalin and the amphetamines, but really the side effects of all of those were quite worrisome. Not so much modafinil, but certainly on the amphetamine side. So I'm interested from just a learning perspective and learning a little bit more about these new drugs. Maybe Dr. Kozlowski can talk about solriamfetol, and when should we be using it? Is it a first line? Is it a second line? Is the data good today that we should start prescribing these for patients with hypersomnia?
That's a great question. I'll have to familiarize myself more with the guidelines and the data from these particular products, but I just could speak to a high level of the fact that it's exciting that new products are emerging on the market. I think there's a lot of hope with that. And then I can just say that, from a regulatory perspective, in order for any product to be approved, the regulators have to conduct a thorough, risk-benefit analysis that comes from very rigid guardrails for, the bar of safety and efficacy. So I think it's really exciting that we have these new treatments that are emerging.
Right. Chris or Vito, have you seen patients come in with these prescriptions yet, Sunosi or solriamfetol?
I haven't seen them yet.
No, okay.
They're still fairly new.
They're fairly new, yes.
And probably very expensive.
Well, yeah, that's the problem with the pitolisant. You're looking at $200 a dose, so it's going to be cost prohibitive for, and the insurance companies are not going to pay for it right away.
Yeah. Has anybody on this panel actually used either the solriamfetol or pitolisant? I'm curious.
Yeah, sure. I'm actually a speaker for pitolisant, believe it or not. But the solriamfetol I've definitely used. Obviously, the indications are for EDS with OSA and also in narcolepsy. But the pitolisant is only for narcolepsy, so you obviously have to go through approval process and show that the patient does have narcolepsy, and usually by an MSLT. And I found that drug to be incredibly helpful. It's not really, believe it or not, it's technically not a stimulant. So it's not a controlled, and the main reason is because it doesn't affect the dopamine transporter, which is sort of the general rule for stimulants. But so it's a weird drug because it takes actually a number of weeks to work. It may take up to 6 weeks for it to work. And it also got an indication not only for narcolepsy, for EDS for narcolepsy, but also for cataplexy. So it definitely decreases cataplectic episodes, which a lot of things do. But so I find that what's really interesting, it's interesting you're asking that, Jagdeep, is that what I found is that that drug and also sodium oxybate, in a narcoleptic patient, it's probably the first time I can actually sort of recapitulate like a normal phenotype. Like patients can really feel pretty good with narcolepsy if they're on one of those two drugs, the sodium oxybate or pitolisant.
Yeah.
Solriamfetol, definitely find it to be helpful. I mean, I don't think it's, I mean, it's maybe a little bit better than modafinil and armodafinil. And the only concern I have with that, just like with modafinil, armodafinil, and stimulants, is whether it's going to interrupt or fragment sleep at night. So you just want to be careful about that. But overall, they're pretty well tolerated.
It does have a very long
interested,
half-life, though.
What's that?
I'm sorry.
But it does have a very long half-life, so, you know.
Yeah, I mean, and that's the thing, even with stimulants, what I found, especially when you look for it, even in you know, in children, especially if they're taking it twice a day, invariably you get fragmentation of sleep at night, and then it sort of becomes a necessity taking it because their fragmentation is significant and they're sleepy the next day. And my little litmus test of that is if they take a holiday, how do they feel? If they tell me that they're exhausted on the days they're not taking that medicine, especially for ADD or ADHD, then I'm worried about it.
I think we're lucky to have a neurologist on this panel. I'm super curious to know, from a neurology perspective, Dr. Sheikh, do you use stimulants in your practice? And you know, any concerns or tips you can give us, you know, from your experience?
Yeah, so I tend to stay away from stimulants, actually. You know, as I mentioned before, migraine is a huge part of my practice, and the stimulants, especially like Adderall, I tend to notice in patients actually worsens their headaches, worsens their migraines. So it's not something I typically go to. If they're already on it, a lot of my, or if they're put on it by their psychiatrist, for example, like some things like Adderall for ADD, I tend to prefer the extended release. That one is not as bad, but yeah, it actually, I've noticed a lot that it can cause worsening of migraines or new headaches sometimes. So I tend to stay away from it. Yeah.
Yeah, I think from my own experience, patients seem to respond either to one stimulant or another, you know, better. And sometimes it's hard to predict. Somebody who might respond very poorly to modafinil might respond to solriamfetol. And so I really, sometimes it's a little bit of a trial and error in these patients. But the cost is an issue. And I think with stimulants, I always worry too about, you know, underlying mental health issues. Because, you know, certainly if somebody is manic or something like that, they can certainly cause, you know, pretty significant issues. And again, long-term side effects, hypertension, tremulousness, headache, you know, all of those things they're not trivial. So I like the fact that, as Dr. Lown was pointing out, I mean, we do have to have a definitive diagnosis. For me, I always feel more comfortable using a stimulant if I can show that the MSLT has, you know, here, mean sleep latency of less than 8, we know that these are true narcoleptics or true primary hypersomnia, then I tend to be a little bit more aggressive. But otherwise, I too like to stay away from these drugs.
So I have a question around just the the issue of hypersomnia to begin with. You know, we have the hypersomnia relative to either OSA or narcolepsy, but you know, I've had patients that they had the the multiple sleep latency tests, and you know, they've been kind of diagnosed as idiopathic, you know, and they tried the modafinil, Provigil, and they're really a management problem, which has become a big problem. So my question really is there any treatment for these, you know, and somebody mentioned the word, you know, you truly have to diagnose them. These undiagnosed idiopathic, you know, they come in as an idiopathic hypersomnia. You know, where do I go with these patients?
So you're asking $1 million question, but you're always asking the good questions. So that is a huge problem, because we know that you know, the frequency of narcolepsy is probably 1 in 2,000. So the numbers aren't high, but both companies, both Harmony, which makes pitolisant, and also Jazz, which makes sodium oxybate, are actually looking at the idiopathic hypersomnia population. They're trying to get an indication for that. which is probably, I don't know how easy it's going to be because, as Christopher mentioned, it's both of those drugs are very expensive. But what we try to do, I'm not saying I'm successful, it's sort of the Wild West, is try to figure out what I can do to defragment their sleep. Because even in the classic, pentet of narcolepsy, one of the symptoms is sleep fragmentation. So you kind of forget about it in narcolepsy. You think, oh, it's more about, EDS and about sleep attacks and about sleep hallucinations and sleep paralysis. A key component is actually that sleep fragmentation. And the argument I would make is the OSA patient that has a lot of EDS really has not just fragmentation from the sleep apnea, but they have this sort of destabilization in sleep in general. And that's why they're so tired. And if you look at it, there was a paper from 2007 Terry Weaver did when she was at UPenn. She looked at actually almost 200 patients with OSA, moderate to severe OSA, and they actually did MSLTs on them while they're using their CPAPs. And what's bizarre is that they had over 50% of patients that were using CPAP for 6 hours or more that still objectively had abnormal MSLTs. So more than half had an abnormal MSLT and they're using their CPAP. So what you're asking, Barry, is $1 million question. How do we get these patients to feel better? And like I said, anecdotally, I try medicine sometimes at night to see if I can defragment their sleep, but it's really empiric. Nobody has any recommendation yet. We're hoping, obviously, for approval theoretically of sodium oxybate, maybe pitolisant in the future. But you're absolutely correct. That thing.
And what is the relation with hypocretin, orexin? Is that are they?
Yeah, so obviously, classically in type 1 narcolepsy, you have low orexin levels. What's interesting about orexin is that not only is it is helpful for stabilization of wakefulness, but it's also helpful for stabilization of sleep. So you really should have like a shutdown of orexin at night, and that obviously can lead to better sleep. And for unclear reasons, the loss of orexin in narcoleptics, and they're usually less than 110 picograms in terms of the CSF measurement, those patients can have tremendous fragmentation of sleep. But the idiopathic hypersomnia patients, or even the type 2 narcoleptic patients, don't really have low orexin levels. So you don't know always why they're sleepy, but I would say at least the general is something that's fragmenting their sleep. And like I said, it's a huge problem, Barry.
I think Barry was asking about hypersomnia in situations like for patients with comorbidities. Barry, did you feel we sort of touched on that with the last section?
Well, I mean, the idea was, I have patients on various hypertension medications, diabetic, and other comorbidity medications, and they come in sometimes with a long list on a loose leaf paper, 25 different medications. The reason I asked this question is I may not be familiar with medications they're taking for other comorbidities, whatever they may be, including, headache medication or other medications that are affecting their sleep, and I'm making the assumption, if I can treat your OSA with whether it's oral appliance therapy, whatever other therapy, that I'm going to improve your daytime sleepiness. And then, the patient comes back and, doc, I'm still tired. And am I missing something in their very common hypertension, diabetic, and other comorbid medications, maybe for stroke or, that is influencing their daytime sleepiness that I may not be aware of, as Dennis, we can tend to be hyper-focused on the OSA and, not really looking at their total medication profile. So I kind of throw that out to the pharmacist.
Very practical question, very practical, because I think all of us deal with hypersomnia and complaints of sleepiness. And maybe some direction from the pharmacists here. Are there medications that are fairly commonly used that we should be having our antennas up that, hey, maybe your sleepiness is because of, let's say, some Benadryl in your over-the-counter thing, or some other medications that are usually commonly associated with sleepiness. Vito, you want to take that?
Well, like when it comes to hypertension, many of the common drugs used can cause sleep disorders. They can keep you awake, or, especially like alpha blockers or beta blockers. They will affect your sleep, and they have to be either adjusted to be taken at a certain time of the day, or maybe try a different product if the patient is eligible for. Like, a safer bet would be like a calcium channel blocker, that will lower your blood pressure without, affecting your sleep much. Also there's certain, steroids, people that are on steroids, that will, make you have difficulty with sleeping as well. So, we usually recommend that you take your steroids, in one dose, usually in the morning is best, to avoid that stimulation from the adrenal gland. And the same thing with SSIRs, people that are on that, initially they make you sleepy, but then as you keep taking them as well, they will cause stimulation after, you take them for a month or two. Many people have a harder time sleeping. So their dose should probably be adjusted, as they've been on them for, a longer period of time.
Give me some common brand names that I would look out for that would alert me that these medications may cause some daytime sleepiness.
Well, let's say with the alpha blockers, tamsulosin can definitely cause a problem. Most people switch to finasteride because it has a better tolerance to sleep. When it comes to beta blockers, atenolol and metoprolol, they're usually very hard on sleeping. So many doctors do switch to calcium channel blockers when it comes to that. That's like nifedipine or verapamil, diltiazem. They have a better profile for sleep. And the steroids and the SSIRs, they all have the same profile. So.
Sounds good. All right. Well, in the thanks for that. Let me look at it this way. In our practice, for example, with obstructive sleep apnea, it's pretty simple in terms of metrics, because we have objective measures like with sleepiness scales, Berlin. You can do a before and after from that perspective. I think it's harder for insomnia. And how do you measure somebody's sleep quality? Let's see. Shall I put Dr. Sheikh on the spot? Do you focus on measuring sort of metrics for sleep before in your patients?
So that's a great question. We have metrics we have something called the MIDAS, which is a metric for migraine disability. And I do have patients sometimes keep apps for their sleep, and we can look at their sleep fragmentation and how many hours they got and how restless they were overnight. But I don't have any, like the MIDAS score is for migraine, and it gives you a number score. And so over time, you can see if their MIDAS score is getting better. I don't have anything specifically for sleep, although.
I think you bring up a really good point, though. And I think that nowadays with the wearables that people are having, they translate what the wearable is saying directly to their sleep quality. I have a lot of people that come in that are sleeping 7-8 hours a day, feeling perfectly fine, but they come in and say, my watch says I don't get enough REM sleep, right? And I think it's important for us to say that, put that in perspective for them. And maybe a little bit of a change of topic, but are wearables something you see a lot for your patients coming in?
Yes. Patients are finding it themselves, and just in general, for migraine, wearables are exploding. For headaches and in neurology, wearables are exploding. There are apps and watches that you wear that can help to detect levels of stress using different biomarkers, sleep, like we mentioned, patients will put in, their own triggers that they think they've had during the day, and then this will analyze all that information. Now, how much of it is validated, because it's so new, and we really don't know if all this information is kind of just, static noise, or if it's actually interpreting it correctly and we're actually giving patients good information. That's all still very new, but it's exploding. Yeah. And patients like it because they feel like they're starting to get kind of control. There's things that because for migraine, what patients tell me all the time is, I want to know what's causing it. I want to know what's causing it. What's the underlying cause? And so it's really hard to sometimes give patients education about the fact that it's genetic. It's something that they have a predisposition to, and what they're interpreting as causes are really triggers for their migraine attacks. But the wearables are really exploding and really important. I think they're going to just keep growing going forward. Yeah.
Yeah, I think, I feel that in the realm of obstructive sleep apnea, we're lucky because you have so many things you can measure. If somebody's on CPAP, you have a whole array of, the AHI, the hours of use, the leak, all of that. So it's fairly simple to do objective measures of outcomes. Not so simple in some of the other disorders like insomnia and hypersomnia, where it's so much of it is subjective.
Right.
Let's see. I'll ask Dr. Vanderbeek, and when you see your patients, and you obviously do a lot of surgery for hypoglossal nerve stimulation and other aspects, I think it's a little bit harder in those patients, right? Because how apart from doing repeated sleep studies, is there any other way you measure sleep quality in those patients?
Yeah, thank you for that question. We do have the habit to use some questionnaire, not only for clinical trials, but also in routine. So when patients arrive through our portal or before they come to the visits, they would fill out like FOSQ-10, Epworth, and at least we can look at those results and of course add some additional questions through the outpatient visit. But I noticed that throughout the years, there's a progressive attention that we put on that sleep quality measuring in the patients, also the patient that receive, for instance, like surgical treatment. Yes, indeed.
Right. I think, being in an academic center, you probably are much more rigorous in terms of follow-up for the patient because you also want those outcomes. And I think that it's something that's lacking certainly in a regular clinical practice like ours. So I appreciate that.
Yeah, I agree. Thank you.
Yeah. And Jonathan, if you're back, did you have any sort of comments on how you measure sleep quality in patients in your practice?
Believe it or not, we really usually don't employ any questionnaires. I actually have become very fond in the last year or so of a sleep profile, called the sleep profiler, which is a digression, but sleep profiler kind of tells me what's really going on with it. It sort of allows me to look under the hood, so to speak. So that's really what we've been relying on. And then the questionnaire from that, but I don't really have a standard sleep quality questionnaire that I use.
Yeah. Now, can you tell me a little bit more about the sleep profiler? Is that?
Yeah, it's Advanced Brain Monitoring is the company.
Oh, I see. Got it. Yeah, I know about that. Sure. Interesting. I must admit that I was a little bit intrigued reading the question about GABA as an effective ingredient in over-the-counter sleep aids. Barry, can you give us some perspective on the question? Maybe Barry is not back. But any of the pharmacists?
I'm back. I just unmuted. Yeah.
Oh, I'm sorry.
Yeah.
Great.
So we know GABA is a sleep initiator, in the brain, and but I've as I mosey around, some of the CVS and other pharmacies, just kind of picking up some of the over-counter medications and looking at the what they call the active ingredients. Many of them will put GABA in as an active ingredient, and I was just wondering, does it translate from you know, what GABA does in the brain organically to, you know, what we're putting in these over the counters. And I think Dr. Kozlowski mentioned valerian root and, you know, some of the other, what they call active ingredients. And, you know, are they effective, or is it just a, or is it just a marketing kind of ingredient and something that's promoted to patients that have no idea what these things are?
Sure. Dr.
No.
Kozlowski, do you want to, or, you know, anybody just want to just jump in on that one?
Yeah, the short answer is no. The GABA doesn't cross the blood-brain barrier when it's taken orally.
Yeah. Okay.
So it's, you know, taking it orally is not going to be effective. There's some studies that say that taking it with L-arginine can boost the amount that crosses because it's
Mhm.
very small, but pretty much it's marketing ploy.
Oh.
A lot of times too with the herbal supplements, just going back to that too, the active ingredient, the amount of active ingredient usually is so small that you really question how much the patient is receiving. And a lot of times, you know, the studies are very limited as well. And so it's a matter of just doing a lot of research, but just, I think anecdotally going back to the fact that there is that strong placebo effect. And if the patient is empowered or has a, you know, desire or belief that it's going to help them, then a lot of times that tends to also play a large role in whether or not a treatment is successful or not.
Let me piggyback this on what Dr. Lown said earlier about adenosine, because, you know, my understanding is adenosine is really the driver of sleep, and, you know, caffeine being, you know, affecting adenosine receptors. And, you know, is there any research around that? Is this something up and coming? Is this, you know, is there any place where over the counters are developed in that area?
I haven't seen anything. So,
But the problem, Barry, is that it's the reason why you produce adenosine is because from glial cells. So glial cells obviously are providing energy to neurons, and by creating ATP, you turn over ATP to adenosine. It's mostly in the basal forebrain that's being studied. The weird part about that, and we know that adenosine is definitely the inducer, like you said. The weird part is actually when you've done ablative studies of the basal forebrain, it actually doesn't have an effect on sleep in experimental animals, which is weird. In other words, if you get rid of the sensing area, it doesn't affect adenosine. Adenosine still works. The other thing is there's been experiments with adenosine being injected into the CSF, and it actually does induce sleep. The problem getting that, like a significant amount concentration in the basal forebrain for it to be effective. I was bringing it up before because, like I said, you know, obviously caffeine's a non-specific adenosine blocker. And the problem really as we get older is it's not adenosine levels. Adenosine levels are actually higher as we get older. We get sleep fragmentation because the receptor for adenosine theoretically is less. There's less receptors. So we're less responsive as we get older. But I don't think there's anything in the short run that's gonna, mimic adenosine in the CNS. That'd be a great idea.
I appreciate it. Thank you.
I think important, especially to point out, because I think, although this is a talk about medications and pharmacy, I think CBTI or cognitive behavioral therapy should be a first-line treatment. I think most of us agree that it should be a first-line agreement for insomnia. And I think the question that's sort of attached to this is critical, which is there any gold standard for CBT that treats sleep disorders? And certainly in my practice, some of the issues I face is that, sure, CBTI, there's good evidence around it, but it's very difficult to find somebody who is trained in CBTI that can see your patients. And so are there alternative sort of modalities that we can use? And there's online CBT programs, and I'm interested in what everybody is doing in terms of offering this sort of important therapeutic option to patients. How do you practically do that? Anybody? And Dr. Van der Weken, since you've asked this question, let me ask you, are you using CBTI in Europe as a standard?
I believe so, yes. We do have this program. We can refer to private practice that we are working with. We also have a program at the sleep lab, actually. So in our own hospital.
Sure.
And yeah, it's sometimes like you mentioned, it's sometimes difficult to assess when you refer patients to this type of therapy, that you are maybe not always aware of what's the content. Is there indeed that standard, or are we achieving the standard? And that's why I put the question. Yeah.
Sure, important. And before I turn it over to Jonathan, I'll just make a comment about my own practice, and I'll maybe we can do a round robin with all the clinicians here. But what I do is, because the resources with PhD clinical psychologists are so low and it's hard to find, I actually have trained my nurse practitioners to do CBTI, and I found that to be very cost effective and very. I think nurse practitioners have incredibly good relationships with patients. They're used to dealing with this sort of educational aspect. So that's been very helpful for me in my practice to be able to send patients to somebody that's, at least much more available than a clinical psychologist. Jonathan, do you do that in your practice?
No, I probably should do that. I haven't done that. What I've relied on really is, like I said, is I usually use Sleepio. I mean, there's actually 3, but I use Sleepio. It's about $300 for the year. And it was theoretically developed by Colin Espy, who is a legitimate, sleep researcher. I found that to be pretty helpful. That's usually what I recommend. And we have like kind of a user code, so you can actually track patients. So if they sign up, they actually, we can get the information of how they're progressing. But I mean, CBTI is pretty standardized. That's one. 2 is that there's actually a weird thing that there's actually a CBTI, a form of CBTI that was looking to get approval as a drug. And they actually, for a short time, had free enrollment. So patients actually could sign up for this and get CBTI, or at least this form, that was meant to be eventually turned into an app. I'm not sure what's happened to that, but it's a weird idea. But that's usually what I do. But Jagdeep, I think that's actually an interesting idea to have one of my nurse practitioners actually be trained that as well.
Yeah, and bringing up Sleepio, obviously, one of the sort of potential solutions would be to use apps, right, to do CBTI, self-directed sort of care for insomnia. Has anybody had any experience with, outside of Sleepio, any of the other apps? I noticed that at the American Academy of Sleep Medicine conference this year, there was this new Somrist, which is, CBTI or an insomnia program anyway, that's online. Anybody using online programs at all?
Actually, that was the program. That's exactly the program I was talking about.
Somrist. Yep. Okay. Yeah. There's another app that I've used called Dayz, D-A-Y-Z-Z. And the interesting part about that, it sort of talks to your wearable and also measures ambient light. So, and then has this feedback that the patient gives every morning. What I found is that it's difficult for patients to sustain interest in an online app when it comes to their CBTI. But I'm not sure if other people are trying different techniques. Dr. Sheikh, do you have any sort of thoughts on insomnia management in your practice?
I do. The one I've had experience with is iSleepio.
Yeah.
But it's not very extensive, to be quite honest. I typically will sometimes refer to a sleep doctor or pulmonologist for if insomnia is really getting in the way.
Mhm. Yeah, it's,
I have a question, but actually, excuse me, to bring in Dr. Pratt with her on the bariatric patient. There must be some cognitive behavioral therapy along with the bariatric patient, and the success of that maybe cross over to sleep disorders. I know that testing for sleep apnea is part of the protocol, but just wondering what the incidence of sleep disorders or insomnia might be, whether it's more or less the same as the general population, or maybe more.
It's really interesting. I'm learning a lot listening to everybody on this meeting. We are very unsophisticated in terms of bariatrics. We kind of label everybody into the sleep apnea bucket. We do sleep studies. And most of our, I always say you can't burn the oceans, right? So we kind of recommend pulmonology, after sleep studies, CPAP, devices, that sort of thing. We do talk about sleep training, setting things aside, exercising as conduits for better sleep. But, we talk about proper amounts of sleep, but we don't do a lot of cognitive behavioral therapy. And a lot of it is really because we're using a lot of our behavioral therapy tools to try to make patients make better choices around food. So it's hard, we can't, it's hard to do everything. For the majority of our patients post-surgery, their sleep and their sleep architecture does change dramatically. We do follow everybody in a database, and it's remarkable how much better their sleep patterns, their wakefulness, their sense of a good night's sleep changes. So before surgery, I would say we don't really delve into many of these things. We certainly don't, we have, just like you, the patients on the whole host and list of medications. So I'm always wary of adding additional medications to that list. So we don't do a lot of medication-based stuff, unless it is something like melatonin. We see a lot of CBD now, a lot of gabapentin. But we don't do a lot of cognitive behavioral therapy before surgery, honestly.
But you do it around the eating and eating habits and better choices around your particular specialty. Is that correct? The CBT?
We do a lot of that. We do some basic education on sleep from the perspective of, are you having trouble sleeping? Do we need to, get a test, make that consult? How much sleep should you be getting? Deep sleep, versus how much time you need to stay in deep sleep, and why you may not be feeling restful. And then dealing with food around those issues, right? Not eating late enough that you get reflux or insulin spikes. But really, we don't delve into behavioral therapy too much around sleep. And some of it is, I guess, the bias that patients aren't sleeping because of more mechanical issues, more so than other things. And some of it is because we need to spend some of that cognitive behavioral therapy hardcore on other things in that immediate post-op period, in that immediate pre-op period, I should say. And then post-operatively, as a lot of the issues start to resolve themselves, we do keep track of how they are doing sleep apnea-wise, and how they're doing around those behavioral trends and how they're feeling. And it's, obviously, and I'm sure, you've all seen some of these patients, they do improve markedly.
And ever get into the relationship between sleep and appetite, like, ghrelin, leptin, and that kind of thing?
100%. So we talk about some of that before. We see dramatic changes afterwards. The fact that if, is it ghrelin? Is it insulin? Is it a combination of both? We talk about that primarily after surgery. Most of our patients, obviously, they've had, anatomic changes. The most common operations we do nowadays are really sleeves, which take up a huge piece of stomach, a huge, amount of the ghrelin production of the stomach. So absolutely important factors, I think. As it is, just the weight, just the decrease in the soft tissue in the palate, and then those type of things that make sleeping easier, make sleep architecture easier, give them more restful amounts of sleep. But sometimes it can be rough, and every once in a while we do have about 5%, 10% of our patients do still need some form of treatment after surgery.
Actually, can I ask you that anecdotally? We know that the meta-analyses on bariatric surgery, the residual HI was about 16, which means they're still moderate. But so in your experience, you're saying the majority of patients can come off therapy after bariatric surgery, or?
Most patients do come off after bariatric surgery. You have to remember, so most of our patients are diagnosed with sleep apnea.
Mm-hmm.
Only a small percentage are actually treated prior to surgery for a whole host of reasons. Post-surgery, a lot of their symptoms improve. The ones that are on sleep, that are on things like CPAP or devices, do end up coming off it. Anecdotally, I've only had I think I've had 2 patients in my career not come off their CPAPs. And even then, only their settings have been greatly reduced.
No, why I bring that up is because in our experience, there's still a lot that have residual OSA. So the other reason why I bring up is because I think there's a perception of patients, if they feel better, especially if their HI is high, and I lower their HI from 80 down to 15, they're going to feel like a rock star. So my only concern is some of those patients aren't being retested. But you're right. I mean, listen, if they don't need to be on a device, that's even better. But
no, I think sleep apnea is probably the most underdiagnosed medical condition, and certainly one of the most undertreated. There was a discussion earlier that we were having about diagnosing the patient and why we should diagnose the patient. And sometimes one of the most important things of doing the sleep studies is so that the patient realizes that there's a problem, because without the patient actually cooperating, whether it's cognitive behavioral therapy or CPAP or a device, and if the patient themselves is not invested in doing those things and going through that period of time where they are, putting the CPAP on, where they are, sleeping next to their loved one with the machine, they have to be invested in undergoing that treatment. One of the most dramatic stories I'll ever tell you is I remember when my son started elementary school, and there was like a sleepaway thing at a farm. And one of the dads, I remember, brought their sleep apnea machine and had to stay indoors plugged in, right? And then the only bathroom obviously was indoors. So everybody was walking by, this guy had his sleep apnea machine on. And I remember thinking to myself, what a committed patient, right? Like, he was sitting there using his sleep apnea machine in the middle of this farm. That's where we want to get most of our patients to. And depending on the level of their disease and how, the level of their disease and how good they feel on the CPAP machine, how good they feel using the device, how good they feel doing the cognitive behavioral therapy, because each one of these is an intervention that, they have to undertake and they have to be committed to doing. I think it's one of the reasons why more patients aren't being treated. We've done great having at-home sleep studies, getting them diagnosed, but the treatment rates really are not staggering.
Thanks, Dr. Pratt. That really thoughtful insights. And I think I probably would compliment the bariatric surgeons on being so aware of the importance of sleep, right? I mean, I think you point out how important behavior is around food, but I've been pretty impressed by how bariatric surgeons have embraced sleep much more than many of the other surgical specialties. So, thanks for your input. I think, again, I've had so many patients come into my clinic, either on or wanting to start CBD. And I think there's issues around, number one, is that safe or not? What is the dose? Are there any regulatory aspects that we should be aware of in terms of CBD? How closely is it associated with medical marijuana, for example? Does one jump from the other? And I'm interested in the pharmacy, perspectives on this. Maybe, Chris, do you want to start us off on this discussion? CBD.
We don't sell CBD in where I am, but CBD, in order to treat sleep, is usually a pretty high dose. So you're talking about 160 milligrams in order for it to affect sleep. I think using CBD is actually helping the underlying conditions that help the patient sleep better. So if you're dealing with the stress and the pain and the anxiety, with the lower doses of CBD, you're probably going to get better sleep results because of that, not so much because it's actually helping the sleep.
Mm-hmm. I'm curious, do any of the prescribers in this panel use or advise CBD to their patients?
Yes, so I do. We're starting to use it a lot more for pain conditions as well as migraine. There's a kind of set of guidelines that I have for CBD. You want to make sure, typically what I prescribe are the oils, and patients can either rub it on their temples and the back of their head, kind of tender points when they have a migraine, or sometimes they'll put it in a little bit of tea or coffee and use it that way. I try to make sure to tell patients to use something that is a really good trusted brand, because you don't want to have the THC component in with your CBD. And the other important part is to make sure that the CBD is in a very good carrier oil, because that makes a difference in terms of breaking down the CBD. So you want to, the one that I like to recommend is MCT oil.
Mm-hmm.
But yeah, now that it's legal in a lot of states, we're starting to get a lot more evidence behind it. So yeah, a lot of times patients will bring it up to me, because they're starting to look into that if they've had migraines for a very long time and have tried a lot of different medications. And I think in terms of sleep, yeah, I think that's right. It helps with their pain. It helps with a little bit of their anxiety. So that helps just in general with them for their sleep as well.
Sure. Yeah.
Can I ask a quick question, to the pharmacists on the panel? How regulated are formulations of CBD by the FDA?
That's a good question. I really don't know. We only carry one particular brand. It's a brand that comes out of Kentucky. It's called Anata Pharmaceuticals, and it's probably one of the first ones that was available to the pharmacists, and it's been slowly picking up. More and more patients have been using it, and I find that patients seem to get some relief from these products because they come back for it. A lot of them use it for, a lot of the patients we have that are using it for focusing. They feel that they're able to focus with better using this product, and in doing so, they say they have a more restful sleep and they feel better throughout the day. But the regulation, I really can't tell you. I don't know.
Yeah, so to my knowledge, they are not regulated, at least not to the level of scrutiny of prescription medications, even over-the-counter medications. The FDA's primary priority is drug safety, even more than efficacy. So they do collect, safety reports. So any patient or even healthcare provider can report any safety issue, even for something like CBD, to the FDA. And of course, if they notice a trend or they amass, certain retrospective data, they can certainly, issue a type of warning or regulation, more so reactively, I would say. But at this time, there is not a lot of regulation. I think this is something that is controversial, and there may even be emerging policy groups that may influence how CBDs are being treated. But I'm really curious to see how this will take shape.
Right. Related to this, what about medical marijuana? Is that something, it's interesting, in Minnesota, there was this short period of time where they actually had an advisory saying that medical marijuana could be prescribed for obstructive sleep apnea, believe it or not. And this was from our state medical board. And all of us sleep physicians said, hey, wait a minute, there's really no evidence that this works. And there was, ultimately the AASM published a pretty strong statement about, look, there's just not enough evidence for medical marijuana, because we were getting patients coming to our office after the Minnesota State Board announced this, and they had to sort of track back. But what about medical marijuana for things like insomnia and chronic pain? Is this something, again, I bet Dr. Sheikh has more of a perspective on this than most of us, but anybody comfortable with medical marijuana? What should we be doing there?
Yeah, I'm outside of CBD, medical marijuana itself, I certainly have a lot of patients ask me, and I have a lot of patients who are using it either on their own or do have a card. But there's just not enough evidence for me to be comfortable myself prescribing it in terms of migraine itself. So I do I ask patients to find someone who is able to prescribe it. And I know you have to, get a certification or do certain steps in order to be able to prescribe it, which I haven't done myself. But I think it's going to be something that we're going to have to become familiar with, because it is something that patients are seeking out themselves. But yeah, I don't necessarily guide patients towards that way, because right now we don't really have any evidence or studies for migraine. And we do have so many other new medications that have come out for migraine. We have so many other kind of things in our toolbox that it's not something I go to, but I think it's important in terms of having the information available when our patients ask us about it.
Sure. I'm curious, and maybe Dr. Vanderveken doesn't know this, it's a little bit outside the scope of your practice, but is there medical marijuana in Europe taking on at all? I don't know if Dr. Vanderveken's still on our panel. Maybe he had to leave for a surgery, but I was just curious, because I think Europe and the United States have pretty different approaches to marijuana. So I was just curious about that.
So the idea of THC being helpful in OSA was actually a study with dronabinol, which was actually positive. Right. It's a small reduction. I mean, it's like anything else. So maybe you could throw it in the armamentarium, but the problem is it's still the Wild West. It's really, we need like a Goodman and Gilman of THC and CBD. I mean, there's so many potentially different forms of this it's crazy. The only sleep data that I know of was actually a neurology article that looked at short-term and long-term. The short-term effects were actually very positive for sleep, but the long-term effects of THC was actually not positive. But it really needs to be formally studied, and like I was intimating, it needs to be studied in terms of specific, different formulations, because there seems to be some. It is amazing how convinced some patients are about CBD and THC, but
right, I agree. Excellent.